of blood sugar at the end of life. And I'm sure you can see why we married it up with Steve's talk tonight. I'm known as the diabetes queen at the hospice, not because, as far as I know, I have diabetes, but because I'm very passionate about making sure we care for patients with diabetes and patients on steroids really well. And why am I so passionate? Well, it all started with Mrs. X, who was a 52-year-old lady with widely metastatic breast cancer. And she came into us for symptom control. She was confused, she had more pain, constipation. But actually we couldn't find any significant reason for this. And we did some things with her drugs, and we treated her constipation, but really there was still no change. And we wondered, well, actually, has she got cerebral metastases? And we started her on dexamethasone. So on the dexamethasone, the patient improved very dramatically, and we were able to discharge her home. And in fact, we undertook a head CT, or we arranged for that, and it showed that she had METs, and some radiotherapy was planned for this lady. But unfortunately, at the hospice outpatient follow-up after a week, she happened to say to my colleague who was seeing her that she was really thirsty and she was peeing a lot. And he quite rightly thought he better check her blood sugar and found it was rather raised. And so we, in short order, needed to readmit her for blood sugar management and review of her dexamethasone dose. Actually, although she was clearly very advanced stage of her disease, all was well from that point of view, and we discharged her again fairly quickly. But this case, although it happened several years ago when I was just a trainee at the hospice, it really set off a train of thought for me that this is something that was actually quite important. It perhaps might not happen that often, but it was really very important for us to pay attention to for our patients. So when I became a consultant shortly after this, what did I do? Well, we adopted the Diabetes UK end of life diabetes care. And from that, it's a big but really easy read document, really helpful. I would highly recommend it to anyone involved in patients in the last year of life. I developed some hospice standards, and these included that we would take good care of looking at blood sugar around a new steroid regime. And if the blood sugar was high before starting the steroids, we'd follow the guidelines. Of course, as I'll come to later in my presentation, sometimes we wouldn't start the steroids in the first place in that situation. For patients started on steroids, we admitted on steroids, we'd check their blood sugar. And we were then, with the help from the Diabetes UK guidance, we now aim, it's our hospice standards, to have a blood sugar aim for our patients of between 6 and 15 millimoles per litre. Now, the Diabetes UK guidance admits that there is no clear evidence for this. This is based on a very practical approach to avoiding hypo or hyperglycemic adverse effects for patients in the last year of life. And actually in the last year of life, as we know, we're really much less worried about the long-term consequences of raised blood sugar. What we're really wanting to make sure is that we don't end up with immediate consequences of either high or low blood sugar. So this much more relaxed regime is appropriate for this patient group. And then the other thing is we always will review the blood sugar management regime at the end of life to make sure that it's balancing up the least impactful way of managing blood sugar for our patients, while also just making sure that they don't, as I say, get symptoms from low or high blood sugar. So we've done masses and masses of staff education, which is why they call me the diabetes queen. I'm constantly going on about it. I make a joke that if you stand around too long on our inpatient unit now, somebody will sidle up to you and measure your blood sugar before you know what's happening. It is a joke, it wouldn't really happen, but I cannot tell you how impressed I am by my hospice colleagues, because they have made huge improvements. And in fact, we were able to do a poster at the Hospice UK National Conference last year on the back of this massive improvement that we have demonstrated following all this work. So this is the End of Life Diabetes UK guidance. It's very easy to access, it's free. That's the link, but actually just put Diabetes UK End of Life into Google and this will pop up. So I would highly recommend it for any palliative care or any other healthcare services that aren't already using it. It's super, super helpful. And critically within it, what we've done is we've printed out and laminated 3 flow charts from it. One to give guidance around steroid management, another one to give guidance when you have patients within the last year of life and you want to decide how to adjust their blood sugar management regime, and then a third one specifically for patients in the last few days or weeks of life. So they're diabetic, so what's the significance now? Steve has touched on this in his talk a little bit. Actually, diabetes has a pretty big impact on patients' quality of life. They're more likely to be in care homes, they're more likely to be frail, and as we all know, frailty is a life-limiting illness. Particularly people who are severely frail are definitely within their last year of life on average. It contributes to dementia, and then actually if you have dementia, people are more likely to get symptoms from their diabetes because they're less able to manage it. And also, of course, there's a significant increase in the risk of renal failure, which of itself is a life-limiting illness. So it's bad news all round. Of course, by the time patients get to us, this is a bit late, but this is, you know, I raise this because it's important for us to know that actually it's really important for us to care for our diabetics properly, but obviously to do it in an appropriate manner for people in the last year of life. So who is suitable for this guidance for the last year of life? Who on earth, if you're overworked, I would say undervalued, because I have enormous respect for my GP colleagues and I know they're having a particularly hard time of it at the minute, but if you're an overworked and undervalued GP and you have a huge population on your books, who is suitable for this end of life diabetes control? Think pig. I'm not being rude. I'm referring to the proactive identification guidance from the GSF, the Gold Standards Framework guidance. So if you ask anyone, if you poke any palliative care physician, you might find they blurt out, ask a surprise question, because that's the thing that actually tells everyone. The surprise question is, would you be surprised if the patient were to die in the next year, month, weeks, etc.? But it's a gut feeling that actually it's often that is as useful as any of the other techniques we have for telling what someone's prognosis is would you be surprised? If you wouldn't be surprised if sadly this patient wouldn't be with us in a year, they would be suitable for this Diabetes UK end of life guidance. I'll come on to some of them in a minute. There are general indicators of decline. Within the GSF guidance, there are some very helpful specific clinical indicators for specific diagnoses: organ failure, frailty, cancer, and this is really worth having a look. If anyone is unclear about this, is a brilliant resource. Again, you can just Google it and it'll come up. And then obviously you should begin considering the gold standards framework process with the patient's permission, but also for the purposes of this talk, if they're diabetic, you should be thinking about using the Diabetes UK guidance. So how do you predict the future? How do you look into that crystal ball? Yes, the surprise question again, but the other things you'd be looking for is that they're generally getting worse. They might have a sentinel event. That might be they're no longer coping at home, admitted to a nursing home, acute deterioration for some reason, but they have on the background of advanced life-limiting disease. Often people with multiple comorbidities, we know that this is increasing in the population, more comorbidities, but the more comorbidities they have, the more likely they're in the last year of life. So they're responding less well to treatment, that's less reversible, and maybe they've chosen to withdraw from dialysis or something. That would be another trigger. they're being admitted to hospital, and they're losing weight, their albumin's low, and they're eligible for benefits. So these are all some of the general triggers for thinking that someone's likely to be in the last year of life without the necessity of using that crystal ball. So the management of diabetes in the last year of life, what are you looking for in general terms? So first of all, as I said already, you're going for this glycemic target of 6 to 15. Now, there is one proviso here, particularly if you have patients who are type 1 diabetics and maybe have been type 1 diabetics, insulin-dependent diabetics since childhood, and have dedicated much of their life to this really good close control of their blood sugar. They may not take kindly to you saying, hey guy, chill, just go for 6 to 15. And actually, not only may they not take kindly, but that may trigger a whole load of other questions and distress on behalf of the patient. So this has to be done sensitively. So you have to look at the patient or their carer expectations of what you're trying to achieve. Your main thing is you wanting to avoid symptoms and complications. You want to avoid symptoms of hypo or hyperglycemia, diabetic ketoacidosis, hyperosmolar symptoms. You want to avoid pressure ulcers, etc., etc. You need to review their diabetic medication and make sure that the regime you have them on is suitable and sensible for a patient in the last year of life. Now, that will take into account the fact that patients are often losing weight in the last year of life. So particularly the type 2 diabetics, and not the type 1 diabetics, but particularly the type 2 diabetics, you will be able to reduce or even in many cases stop their diabetic medication. When we do audits, when we do our audits at the hospice, looking for patients who are diabetic, what we frequently find is we pick up 5 to 10 times as many patients on steroids, unsurprisingly, as for each patient with diabetes. Why is that? Because actually the way we're quickly looking for diabetics is we're looking at their drug chart and we're looking for diabetic drugs. And actually, by the time they get to us in the hospice, a lot of them have often lost so much weight that they may not be on these drugs. But then you drill down and you might find it in their past medical history that they were diabetic on treatment. They're now just diet controlled. So you need to look at other effects of other medication. A lot of patients with diabetes will be on cardiac drugs. They may be on drugs relating to renal impairment, etc. So say they are on antihypertensives if they're losing weight. They may well need a reduction or even cessation of this medication. Other drugs like, for example, aspirin, which they may be on for reduction in the clotting, that actually this may then have quite a significant impairment effect on their kidneys, which are then increasingly frail at this stage, but also they may get gastric side effects more easily as they get more frail towards the end of life. So there's also the effect of the underlying disease, which, as I've already said, they may be losing weight. There may be other effects. So, for example, if you had, say, pancreatic or gastric carcinoma, you may be feeling sick. So perhaps somebody who was previously on metformin, this may no longer be a suitable drug for them. And then at the very end of life, you do need to make adjustments, and I will come on to that. But usually that means once daily insulin if treatment is needed at all, just to make sure that the last few days of life is not impaired. They don't get symptoms from high blood sugar. So if you look at the Diabetes UK guidance, what they do is they very sensibly RAG rate, red, amber, green rate blood sugar management. So they start with the green when someone's got a prognosis of months. And so what their general broad brushstroke recommendation is, you try to go, if for patients who need it, that you go for insulin alone instead of combination regimes, and you simplify their insulin regimes. Now, obviously, depending on who you are, you might well want to ask the diabetic team, the diabetic nurse, to you might want to alert them and work with them to do this. I'm not suggesting that we should all become expert diabetologists, but this is what the Diabetes UK recommendations are. So amber If you haven't already taken the steps in green, you then need to be reviewing this. But amber, if you've got someone who's presenting for the first time with a prognosis of weeks, they will have a huge emotional response to the situation they find themselves in. And simplifying their diabetes management may be one way that you can help to make their life a little bit easier at this time. But as I say, just be aware of patients who've been closely monitoring their blood sugar all their life. They may really cling to that. It may feel an area of safety, paradoxically, at this time. And then in the last days, insulin-dependent diabetics must continue insulin until death. I was saying to one of my trainees just the other day that actually, you know, you continue insulin in an insulin-dependent diabetic until death, and you continue warfarin in patients with a metal valve, but most other things other than symptom control, you try and stop. But those are the two exceptions. So I'm not planning, don't fret, to go through this in detail, but this is one of the tables from the Diabetes UK guidance that talks about how one could review the non-insulin therapies for blood sugar management in these patients. It would clearly have to be individualized for the patient. And again, I very much, you know, I hold my hand up. I would be doing this in conjunction with the diabetes nurse because I'm a palliative care expert. I'm not a diabetes expert. You know, I look after people with all life limiting diagnoses. I can't possibly be expert in everything. So what do? You have a patient who very commonly, you know, I just don't have much appetite. We know anyone who looks after people with life-limiting illness is a very emotive thing for patients and actually their family, because it feels to families that feeding their loved one is one of the most basic things you can do to show your love, show your care. But as we know, cachexia is not as simple as just not having an appetite. It's actually a highly complex, widespread inflammatory process involving multiple cytokines and chemicals within the body. So actually, it's not much surprise that patients with any life-limiting illness will lose a lot of weight. So what do you do for people who are on medications to control their blood sugar? So you try and adjust the medication, not the diet. So, you know, we have patients in the hospice who have lost their appetite, but they want to exist on a diet of Mr. Kipling and those dreadful sweets, Haribos. That's it. I don't like them, but my kids love them. Haribos. It's not brilliant. And if we possibly can, we will say, okay, that's what they want to eat. We will try and adjust their medication if we can, rather than the diet. Not always possible, but that's the goal, because actually you want to allow them to eat when they have some appetite. You want to allow them to eat, because eating is just such a big issue for patients at this stage, directly opposite to what Steve was talking about earlier. So you relax their diabetic diet restrictions. You need to realize that if you're using long-acting drugs like long-acting sulfonylureas, if they're eating not in a non-regular way, very small meals, may or may not want to eat, these drugs may not be a really good idea, because you may get hypoglycemia. But on the other hand, although metformin solution can be good if they're having problems with tablets, metformin can have quite significant gastric side effects. So also may not be a good idea from that point of view. And so often we may find, surprisingly, that a once daily low dose insulin may be the best option, because it just will be enough, perhaps combined with some rapid acting insulin. If they are showing signs of hypoglycemia, it may be just the right way to control their blood sugar. So insulin pumps. Now, one of the most important things, and another reason to refer to your diabetes team, is actually, if someone's using a pump, it's really important if they diagnosed with life-limiting illness, for them to liaise with their pump team, because actually there's all sorts of things that they need to discuss with them and to review their targets, but to tweak the pump. But there's no reason why, unless the patient wants to, or unless it's felt it will be sensible, there's no reason why they can't carry on using their pump. In fact, in the last days of life, we are all very used in the hospice world to know that loved ones and carers, it can be really, really important for them to be given specific things to do in the last days of life. And because it really helps them to feel involved, make them feel that they are caring for their dying relatives. And actually, carers who've been trained to use the pump and also flash glucose monitoring can continue to use this and feel a real sense of responsibility, and it can be a really positive thing for them to do at the end of life. And we've had a number of patients who come into the hospice who've had quite complex insulin regimes or used pumps, and actually their partners have gradually taken over control of it really, really successfully, and it's been a real win-win situation. So the other thing to realize, and part of the reason why the blood sugar range 6 to 15 is that is an increased risk of hypoglycemia in patients with life-limiting illnesses for all the reasons that I have listed there. So we really, we want to avoid that. And the other thing is actually patients who are pale, sweaty, fairly unresponsive, a bit confused. That's really tricky to know whether they're hypoglycemic or whether they're actually just less well. Maybe they're having an adverse effect from some of the symptom control medication we're using. So it's quite important we try and avoid that if possible for a number of different reasons. So let's talk about a case history. Mrs. G, who had motor neurone disease and was a type 2 diabetic. She came into the hospice and we reviewed her glycemic control, and as per our standards, discussed with her our new aim of going for 6 to 15. And as we often do, we reduce the frequency of her testing. So it's always a balance of not wanting to be testing the patients too frequently versus making sure that we're taking adequate control of their blood sugars. She'd been on a previous regime that we then changed to metformin via a PEG, but unfortunately, probably unsurprisingly in retrospect, she didn't really tolerate that. She also wasn't then tolerating her PEG feed. She started losing weight. So actually what we did is we were able to stop the metformin in the end, which helped with some of the side effects of the metformin, but because she was losing weight, she didn't need it anyway. So then we just did once daily blood sugars and until the last days of life, when actually we didn't. We did continue the once daily blood sugars just because occasionally we would need to give her a little bit of Atrapia, but generally we didn't need to do anything. And then in the last days of life, we didn't need to do any monitoring. So this is just a classic example of how we manage blood sugars for people in the last period of their life. So actually, what is the Diabetes UK guidance? So for type 1 diabetic, they suggest Noninsulin, Glargine or Degludec, and then you monitor their blood glucose at tea time, and you then adjust the dose by 10 or 20% up or down as indicated by whether the blood sugar is below 8 or above 20. And then if you're type 2 diabetics, you stop the tablets and the GLP-1 injections and the insulin where possible. If you do continue the insulin, again, long-acting, 25% dose reduction. And then you can have, we always have on the PRN side of the drug chart, we have rapid-acting insulin. They recommend 6 units of the blood sugars over 8. I'm not necessarily quite that prescriptive. I'll slightly adjust that depending on the patient, but something along those lines. There is no evidence, as they would always say. Palliative care physicians use steroids a lot, not personally, for their patients. And of course, steroids increase the risk of your blood sugars going up. So if you are wanting to start your steroid regime, what you should do, what our standards are, to check a random blood sugar prior to starting. And actually, this guidance I got here is the previous edition of the Diabetes UK guidance. They've actually slightly changed it. They've made it slightly more complicated. I don't like that. I've decided to stick with the previous one because as far as I can see from having read it, there's no clear evidence. I think it's probably just somebody else having their expert opinion thinking it should be slightly different. And this seems to have served us very well at the hospice. And, you know, actually, the thing with this is you're then really having to say, if you've got somebody before you start the steroids who is likely for their blood sugars to go up, either because they're a known diabetic or because you take a random blood sugar and it's a bit high, you then really need to decide, are the steroids sort of optional? Are the steroids quite helpful, or are the steroids essential? So I'm just going to check that. No, I can't check. I was just a bit worried that there was some comments in the chat box, but I can't actually see it at the minute. So optional steroids. Mr. Y, metastatic colonic carcinoma in his last weeks of life. He's got a lot of reasons why one could consider steroids. So poor appetite is the one that always gets is always the one that we kind of might think of as steroids, but actually he's got bone mets, he's got nausea, possibly a bit of daytime drowsiness. I'm not advocating these as steroid indications, but they are ones that we have occasionally used steroids for or do need to. And the really critical thing in that is that the patient and the partner are distressed by these symptoms. So would you consider dexamethasone? Actually, no, I wouldn't initially. What I would do first is, particularly for the appetite, is you manage the pain, you manage the nausea. The most important way to manage appetite in our patients is to make sure you've controlled their other symptoms. And it is amazing how magically their appetite will improve as much as it's going to. It won't become normal usually because they have underlying cachexia, etc. But that if you make them comfortable, particularly if you control nausea, their appetite will get much better. And also mood. I'm surprised, you know, if you're sitting there feeling sick as a dog and in a lot of pain, no one's going to feel brilliant, are they? And then they may become less drowsy because they're sleeping better. If you were at this stage then going to consider dexamethasone, I'd really want to make sure that you check their blood sugar, because I do not think that if you give dex for poor appetite, it only increases actually fluid and fat. It doesn't increase muscle. It has a very short duration. There's a lot of side effects. So I only will advocate use of dex in poor appetite, and even then for a very short period, if it's giving the patient and their family or just the patient real psychological distress. So those were optional steroids. Here are some important steroids. So Mrs. M, advanced lung cancer, was getting worse, and she actually had a fit. And this was worrying because she didn't have a history of epilepsy, so why was she fitting? Her TEP, her treatment escalation plan, said that she didn't want to be transferred acutely to the hospital. So even though she had lost capacity in the immediate period after the fit, we were able to refer to the TEP. But we felt she had a likely diagnosis of cerebral metastases, and it seemed a reasonable step at this point to start her on dexamethasone. So this controlled her fitting, but her blood sugars then started rising. So indeed later she did have cerebral mets diagnosed on imaging, and she was given one fraction of radiotherapy, and Keppra, the drug that is now used for all fitting and under all circumstances, is started. And just I'm going to take this opportunity just to say that Keppra levetiracetam is a good drug and is used for everybody who fits nowadays, but please bear in mind that it has a significant risk of causing anxiety as a side effect. And in our patients with life-limiting illnesses, anxiety is already quite a big factor. So if you have a patient who's on Keppra and they're very anxious, just think a little bit about whether it might be the Keppra, and if an alternative such as sodium valproate might be a better option. So with this lady, we stopped the dex and the blood sugars then became controlled. So I would say that, you know, what we did is we controlled the fitting by another way. We could have, if If she had had other symptoms, other neurological symptoms, I might well have considered continuing as low a dose of dex as we could get away with and controlling her blood sugars. But in this case, we were able to manage it just with the Keppra at this point. So then essential steroids that I really don't feel there isn't another option. So Mr. Z had esophageal carcinoma, and he presented with symptoms that would immediately make anyone worried about spinal cord compression. And so, of course, we started 16 milligrams of dexamethasone, and he had spinal cord compression and was treated with radiotherapy, and was then transferred back to the hospice. His blood sugars were rather higher than we would have liked them to be. So we put him, we're very old fashioned, we put him on glycoside, and actually that did the trick. And then as one does after radiotherapy, we wean the steroids, and then we're able to actually reduce the glycoside over time and stop it once he'd come off the steroids. So in this case, the dexamethasone absolutely had to be started. If you don't start dexamethasone in someone with spinal cord compression, you risk some pretty serious consequences. So I would say in these ones, you must start the dex, you control the blood sugar. And then the opposite is with appetite. I'm not that keen on steroids for appetite. Particularly if it's going to upset their blood sugars, you're going to have a real problem. And then cerebral met somewhere in between, depending on the circumstances. So that's time for questions. What I'm going to do